in Nigeria when it comes to malnutrition in the community setting. We hear a lot about malnutrition. We hear about malnourished patients, pediatrics. There's a lot of information in the literature, a lot of talk about what's actually happening. We also hear about the food insecurity. But what we don't hear enough of, or probably not much, is what is actually happening in the hospital. And I'm saying this so that you all will understand what I'm trying to get at here. So if you look at what has happened historically, even in US years ago, in the 70s, before this physician, Charles Butterworth, in 1974, really started bringing to people's attention that, guys, we have a skeleton in the hospital's closet, which is hospital malnutrition. And he highlighted the frequent oversight, underdiagnosis, undertreatment of malnutrition in hospital settings. I think that's what's indirectly happening in the African continent, in Nigeria, in Ghana, that we're paying a lot of attention to what's going on in the community, but now it's time for us to start looking to see what is actually happening in the hospital and what is the implication of us not doing that, not only clinical implication, but economic implication, So what is the current situation? So if you look at current situation, the problem of this lack of awareness, at least in the healthcare setting, still persists today. With the global prevalence of malnutrition in adults and pediatrics ranging between 15 to 76%. Next slide. But it would be good to kind of have an idea of what is a good definition for malnutrition. It's a deficiency or excess in nutrients, which causes an inflammatory response leading to diminished function and alteration in body composition. Typically, it can be referred to as undernutrition, such as wasting, stunting, like in the case of the pediatrics patients, and underweight. May also refer to micronutrient-related malnutrition, overnourishment, and if the overweight, obese, and diet-related non-transmissible diseases. Aspen has done a lot of work, research-wise, and that's one of the things that we'll see that we need to learn from, we need to move towards, and you'll hear a little bit more about suggestions we have. If you look at globally, 37% of critically ill patients are malnourished, as quoted by Aspen. Next slide. So who are the patients who are at risk? Again, looking at the healthcare system, the hospital. People that have weight gain or loss of 20% of ideal body weight, greater than 10% of weight loss. But I want to talk more about the MPO, nothing by mouth. Patients who get admitted to the hospital, maybe for a surgical procedure. And typically, you probably have to keep them MPO, meaning you don't want to have them take anything by mouth, plain IV fluids for greater than 5 days. Such patients could probably get malnourished while they're there in the hospital, even if their nutritional status was borderline when they came in. Patients who have high metabolic demands. Examples would be that your trauma patients, your septic patients, your burn patients, your cancer patients who are on chemotherapy agents, steroids, or immunosuppressants. Even some of your patients who have chronic diseases, like your diabetic patients, who probably, because of their illness, had not been eating well, and they get admitted and you don't pay attention, So if you're looking at the impact of malnutrition, you all can see from the slides here, the different kind of things, that the weight loss, like I mentioned, muscle wasting, increased risk of fractures, increased risk of hospital admissions, which I'm going to talk about, confusion. So ASPEN is pretty much saying that when they looked at the data over the past 5 years, malnutrition deaths have more than doubled. And that's in a developed country. How much more us, developing countries? So I'm just trying to let you all see what this data thing is looking at. Next slide. Looking at the epidemiology of malnutrition. In developing countries, malnutrition affects 1 in 3 patients admitted to the hospital. If a patient came in malnourished upon admission, approximately 1 in 3 may become malnourished during their stay. And I'll talk a little bit more about that, and especially when I start talking about the screening. Approximately 20 to 50% of adult hospitalized patients are malnourished, the most common type being the protein calorie malnutrition. Consequences of malnutrition. Why are we talking about malnutrition? Why is it important, especially in this patient population? ASPEN, again, has done a lot of work, and they continue to do research studies, trying to get data, and I'm hoping by the grace of God, that's something that we're going to start seeing in Africa, in Nigeria, because you have to have data to be able to speak. What they're saying in this slide is that malnourished patients experience longer hospital stays, they experience higher medical costs, and they also experience increased mortality. Those are definitely. There was a case that I was aware of here in Nigeria, of a young boy. I'm pretty sure that what was being said was that the boy's intestine was stolen during surgery. But what I'm suspecting, not having much information, is that most likely this boy ended up with a short gut syndrome secondary to the complications of the surgery. With short gut syndrome, the only way you can maintain that individual's nutrition is parenteral nutrition support. Such an individual, because the intestine is short, it's not been absorbed, and I'm glad we have a physician here in the audience, whatever you give that patient, they're not going to absorb it. So the only way you have to feed them and maintain them is parenterally.
The factors that contribute to malnutrition in the hospitalized patients, we can categorize them into 2 main factors, those that are related to the patients and those that are related to the healthcare provider. So as you can see in this slide, patient-related factors can be non-illness factors or illness-related factors. So the non-illness factors may stem from socioeconomic circumstances, behavioral, environmental problems, which lead to reduced intake, and then the patient becomes malnourished. Or we have illness-related factors, ranging from things like malabsorption problems, nutrient loss, inflammation, hypermetabolism. At the end of the day, the patient becomes malnourished. And this leads to the outcomes that we listed in the slide. Patient may be prone to recurrent infections, immune dysfunction, delayed healing, and prolonged hospital stay. And what is more concerning is the fact that malnutrition in hospitalized patients can even come from the healthcare providers too. In some studies in children and even in adults, we see that lack of standardized nutritional care practices and validated screening tools may lead to the occurrence of malnutrition. Lack of screening on admission, so the patients are not followed up when they are on inpatient care during the hospital stay. Failure to prioritize nutrition and lack of dietetic referral leads to inadequate nutrition management plans for many of our patients. There may be failure to document poor nutritional status in the hospital charts, inadequate nutritional intake either due to the medical procedures or hospital food may result in malnutrition. Just like the patient Dr. Pounds alluded to, who had a short gut syndrome and was not absorbing well and all that, that can Some of these are surgical procedures can lead to malnutrition in the hospitalized patient. Also, inadequate nutritional education and training of the hospital staff can actually contribute to the occurrence of malnutrition, as the case may be. Which group of hospitalized patients are mostly affected? Studies have shown that in the adults, the geriatric age group are the mostly affected, and then the gynecologic patients are the least affected. Some other authors have looked at this and said, okay, it's the surgical patients compared to the medical patients that are mostly affected by hospital-based malnutrition. In children, infections, metabolic problems, surgical issues also contributes to the occurrence of malnutrition. So what is the role of the multidisciplinary team? This team is a team of healthcare providers from different disciplines or professions who work towards a common goal, in this case to achieve nutritional care in the hospitalized patients. And the concept of MDT has been well established actually. It's been there for a while, but in recent years, the greater focus is being paid for MDTs to improve patient outcomes. We have different types of MDTs. We have the community-based one or the hospital-based one, and we'll be focusing more on the hospital-based one since we are talking about improving and combating malnutrition in the hospital setting this afternoon. We also have the specialist and the non-specialist teams. When we are talking about nutritional care, we are referring to a coordinated approach to the delivery of food and fluids by different healthcare professionals with the view that the patient is an individual who has peculiar needs and preferences. So Dr. Pounds has said a lot about the professionals that are involved in the MDTs in the nutrition care. The list is there as we have seen. I just want to point out that apart from the healthcare professionals, the social workers, even the relatives of patients, and the parents of our children, volunteers, can also contribute meaningfully to the work of the MDTs. So it's not just the physicians and the healthcare professionals or allied healthcare professionals, even volunteers from outside, the patients' relatives and the parents of our children can also make meaningful contributions to the multidisciplinary teams to combat malnutrition in the hospital setting.
We have some malnutrition screening tools, such as malnutrition screening tool, MST. It's a brief questionnaire that assesses recent weight loss and appetite changes. We have malnutrition universal screening tool, MUST. It uses a 5-step tool that includes body mass index, unintentional weight loss, and the effect of acute disease on intake. And we have another tool called mini nutrition assessment. It's mini nutrition assessment short form. It's specifically designed for the elderly. It assesses the factors such as weight loss, the mobility, and dietary intake of the patient. Then the next on the nutrition screening tool is the short nutritional assessment questionnaire. It's a tool that screens for malnutrition in hospital patients by assessing their weight, body mass index, and dietary intake. Next on the list is nutrition risk screening of 2002. It's a screening tool that includes an assessment of disease severity and nutritional status. Here you have one of the tools here. It uses the 5 steps that the nutritional screening tool is co-opted by WASPEN for the pediatric patients. Here you have the surname is well itemized, the surname, the date of birth, and all the information pertaining to the patient. The first step is it uses the body mass index which shows various categories of assessment. And when you can use no as for 0, then yes, when such a condition presents, it is called as 2. We move to the second step in that order. When the children has lost weight, you ask if the child has lost weight recently, then you score accordingly. Then the third step tells you, has the child had a reduced intake? That's when there's no appetite. The decreased appetite, you will score 1. If there's no reduced appetite or intake of food by the child, you put a no. And you move on to the fourth stage. You will ask, will child's nutrition be affected by the recent admission or condition for at least the next week? If a child, we were told from the previous presenter that if somebody is on admission and the person is on, for example, NIPA oral for five days, is treatment modality, a way of resting the GIT tract, that person is likely to have nutritional issues. Then you calculate the total at the end. Here, the same assessment continues. Here we use the body mass index for scoring. That you have 0 if you have repeated the score of 1 in 1 week. Then in that order, you move to 1 if there's a repeated protein body mass index of that is low, so for about 3 days. Then you move on to the second step, whereby you request for the dietitian to review when there are challenges in your assessment. For the body mass index calculation, we use the weight and height. If it is above below less than 18.5, it indicates the potential for malnutrition. Less than 15 is considered normal. Then screening for children that are below 5 years, you compare the height of the child to the age. Then weight for age and weight for height. Then we equally use the MOAC, mid upper arm circumference, to assess their nutritional status. In this case, you measure between the shoulder joint and the elbow joint, the midpoint. The calipers is attached to the midpoint, is graduated, and you read accordingly. It's recorded in centimeters. Then we use the growth chart, growth and development, for physical assessment and mental development of the child. Well, this type of chart, for example, is used in Well Baby Clinic, whereby when the children come, you assess, you weigh them, and it's plotted in graph on monthly basis, or at each clinic attendance. You see if the child is appreciating in weight or static, or if the child is growing as the child should be.
What is nutrition assessment? Just as the physical examination is the cornerstone of medical assessment, so nutrition assessment also provides the foundation for the nutrition care process. So without the nutrition assessment, there can't be nutrition diagnosis, and malnutrition intervention. So it is from this that informations are gathered that leads to nutrition problems, identify, and the nutrition diagnosis can be determined. So what then is nutrition assessment? Nutrition assessment can be defined as a systematic process of collecting and interpreting information in order to make decisions about the nature and cause of nutrition-related health issues that affects individual, a group, or a population. Even after the nutrition intervention have been made and have been put into place, nutrition assessment data also serve as a benchmark with which to measure the effectiveness of treatment. So meaning that without the nutrition assessment, problem cannot be identified. Nutrition diagnosis, which can only be treated by the dietitian nutritionist, cannot be done, and nutrition intervention cannot be put into place. So what are the importance of early detection of malnutrition with this nutrition assessment? To identify those at risk of malnutrition, like what we did at pediatrics outpatients today, to identify those patients at risk of malnutrition, to identify those who need medical nutrition therapy, the inpatient that have a longer stay in the hospital, to measure the growth using the growth charts at our immunization clinic to know the weight, the adequate weight for the age of that particular patient or child, to identify impediments to nutrient digestion, absorption, and utilizations. Next slide. Also, to importance of early detection, to discover practices that can lead to malnutrition or increase infections, instruct for nutrition education and counseling, initiate a proper nutrition care with the help of the nutrition assessment. Now, what are the key components or main domain of nutrition assessment? We have anthropometry. Next slide. We have anthropometry, which put into consideration the BMI, the weight, the waist circumference, the mark, the height, the body composition, the tricep, skin fold, and the likes. All this information helps define the nutrition problem in a patient, whereby it will be easy to make a diagnosis and put up nutrition intervention. So we have biochemical investigations. Information from this provides us the medical procedures, provides us and supports the appropriate nutrition care. Now we have clinical physical assessment, which we also called nutrition focused physical findings in nutrition care process. And this, in addition, with physical examination carried out by medical practitioners or nursing staff, dietitian also carried out routine examination. And the purpose of this is to assess the patient for signs and symptoms consistent with malnutrition or in a specific nutrient deficiency. And what are those nutrition focused physical findings? We have like pallor, we have dehydration, we have the severe, when the patient is severely malnourished and the likes. So when we talk about the dietary take into consideration the food records, the 24-hour dietary record, the food pattern, the preferences of this particular patient, the frequency of feeding. We put all this together and identify where the problem can lie, the nutrition problem, for us to take the appropriate diagnosis and nutrition intervention. And we looked at the environmental and behavioral and social factors too. The cultural behavior, the cultural practices, the behavior, the environmental, where the patient grows up, the backgrounds of this particular patients are being put into consideration.
When you think about research, a lot of times it may be a very daunting idea. And that's because when we think of research, we have to think of a systematic way to collect data. Oftentimes we're thinking financial restrictions, we're thinking inability or not having the know-how to accomplish research. But I'm going to share with you some simple steps to take to ensure that research is integrated in every aspect of your care. So the first thing is, research doesn't have to be daunting. We can start with low-hanging fruits. I'll give you an example. In my care as a clinical nutrition specialist at the pediatric hospital here, upon starting, I recognized, hey, we don't have much data for patients when we start our lipid therapy with parenteral nutrition. How can I find information about lipid therapy and when to start and how to monitor, especially for the littlest of care of babies? From that idea, you can start to develop simple strategies to accomplish that. Number one, do you have the data or the ability to collect the data rapidly? So fortunately for our institution, we have an EHR that we can just look back to see all the patients in the NICU who have received lipids therapy, intravenous lipid therapy, and see if we collected labs, how we can evaluate the lab triglyceride lab collection based on the patients who received lipids. So low-hanging fruits. We don't need to actually make it too complicated, especially when you're starting off at a new institution or starting off with a protocol or intervention at your institution. We've had lots of great discussion this morning about malnutrition screening in the hospital. I'll give you another example. Let's say you start malnutrition screening for all patients in your institution. Can you compare, for patients you have, from the time you implemented that protocol of assessing, what is your morbidity, mortality? Because oftentimes when you assess something, you're treating it, right? You're addressing it. So comparing morbidity before that intervention was implemented versus morbidity after intervention was implemented to show the value of implementing a malnutrition screen. Crucial to a successful research is the ability to identify early adopters and collaborators. Research is extremely difficult to be done in silo. So when I have an idea, I first of all reach out to my partner in my team, my other pharmacist, to ensure that he can, support me and also, contribute to the research as well in his own way. Another is, reaching out to my physician team because, the data is often driven by their care. And so engaging in my fellow clinicians. But another really, really great opportunity is to get the involvement of learners. So your residents and your students, they can contribute significantly to the movement and to the acceleration of your research idea. I have worked with groups of students, and we've been able to, start with an idea. They worked on the data collection. They worked on the first draft of the article, and within 6 months, we were able to submit an article for publication, which is, oftentimes the end goal, but for student learning. But it's very amazing how, the effort of student can really help you push through as a clinician. When you're thinking of research, it is vital that you...
Some points that continue to be, that keeps me up at night when it pertains to the nutrition support in Nigeria. The availability and affordability of products, that's number one. And I'm happy to report that WASPEN, has aggressively been pursuing this, and we are currently working with a manufacturing company that has an interest in manufacturing the parenteral nutrition product in Nigeria. I'm hoping, by God's grace, that by this time next year, which we will have another malnutrition awareness week going forward, that we'll be saying something different, all right? Then the second that will be reporting, saying something different and have positive results or information to report. Because I feel strongly that if we have them manufactured in Nigeria, then we will have them easily available and also affordable. We're also going to be looking at the insurance. I'm not an expert on that, but I think that's something we're going to also look at in terms of it being affordable. We're working with the Federal Ministry of Health to see how support can be given to hospitalized patients when it comes to parenteral nutrition. I will let you know, I was at a conference that they had this week, and they were talking about all the donor support for malnutrition-related issues in the community. I really did not hear anything about any kind of support for hospitalized patients. And that's what WASPEN is looking at. How can we start talking to people, the powers to be, to make sure that we're supporting what's going on with our hospitalized patients. In the neonatal patient population, you are correct. Parenteral nutrition is key. Enteral nutrition is also key. And then multidisciplinary team approach is definitely another key point. So with what we're doing with WASPEN, really focusing on trying to see and introduce nutrition support teams, nutrition committees in all these different institutions, that would be one of the things that they definitely are going to be looking at.